Welcome to another episode of Every Possible Advantage. Today, I'm joined by my co-host, Pratik Patel, and we're very excited to welcome a special guest, Dr. Pablo Sanchez, Surgical Director of the Lung Transplant Program at the University of Pittsburgh Medical Center. Welcome, Dr. Sanchez.
Hi, how are you guys doing?
Excellent. Thank you for coming. We really appreciate you making the time in your busy schedule. We're really looking forward to the conversation. There's so much going on in lung transplantation right now. One of the things I'd like to start with, though, is learning a little bit about you and how you ended up in transplantation. And there's a lot of options in the field of medicine. When you were studying, what really attracted you towards transplantation?
Well, thank you for the invitation. I think I'm not exception to what happened to most of us, you know. I just had a few mentors that were super dedicated to lung transplants, and I got the opportunity to train with them and under them, and for a lot of different reasons, you know, you end up absorbing this energy around this passion for trying to change people's life by giving the opportunity to have be disconnected from oxygen and have normal lungs again. So that was exactly my case. I left Argentina to be trained in Brazil. At the time, the program that I was doing, my thoracic surgery residency, it was the only lung transplant program in Central and South America. We got patients from everywhere in South America, and it was a busy program for our size. And my chief, he was and he still is extremely passionate about lung transplant. And it was very difficult, I think, for any of us not to absorb the energy to the point that many of my colleagues are lung transplant surgeons. I guess we all, I think he indoctrinated us all, you know. So, yeah, I don't think I'm any different in that case. And of course, then, you know, you start practicing and you understand why he was so dedicated to this field. Just the opportunity to be able to, as I was saying, you know, to be able to provide people with a second opportunity, it's intoxicating sometimes.
I can only imagine, and truly thank you for what you do. And I think it's always special when you have in your career or your life those special mentors who can really show you an incredible path forward and instill that kind of energy, as you're saying.
Yeah.
Yeah. No, absolutely. Now you're at the University of Pittsburgh Medical Center, which has grown. You're at nearly 60 lungs a year. It's a fantastic accomplishment, and you're one of the top third of transplant centers in the country. I was looking up your numbers. You do a lot of longer distances. Nearly 2/3 of the cases are over 250 miles.
Yeah.
I'd imagine that some of this has been driven lately by the changes. You know, obviously the continued allocation score just changed.
Yeah, of course. Well, you know, there's a lot of history at Pittsburgh in transplant, particularly with lung transplant. We have almost 40 years of lung transplant history. So this is, you know, I'm just one of the surgical directors. There have been a lot of great people that occupy this chair before me. And we are pretty close to 2,500 lung transplants as a program, which is an incredible accomplishment for our institution. We have seen, just because we are in a region that is extremely competitive, an increase in how far we had to travel for organs. I don't think this is specific to us. I think it's something that the country as a whole is experiencing. It has to do a lot with a few changes, particularly the 2018 change and the 250, you know, the removal of what we would call the DSA, the donor specific areas, service areas. And then later on now with the introduction of CAS, I believe that we are close to 95% of our organs of our lung donors are fly out.
Wow.
So our local utilization is extremely low, and yeah, it feels like the team is always in the air, going to a different city or a different state, searching for an organ that can change somebody's life. So yeah, we're flying all the time.
I've got to imagine that's going to be a real strain sometimes on the team, especially with a program with your volume, your size.
Yeah, it's definitely, we rely on a lot of different things. We rely also on procurement services. We rely on people that we have trained during the years. We rely on friends that are in a particular institution or city that can help us. So the team doesn't have to be in the air all the time. But we still do a significant number of our own procurements. I'll say a little over half. Just because we were part of the DCD utilizations, increased utilization effort within UNOS. So I think in the last year have quadrupled our number of DCD use. And the DCDs is something that we still like to do ourselves, because it requires a little bit of a soft touch with the process and some more in-depth conversation sometimes between the procuring team and the transplanting team. So we have, a lot of what we do is on being able to communicate the quality of the organ through either pictures or videos or a conversation. So, I understand my team, just because we work together so much, we kind of have the same wavelength sometimes about what can work and what cannot work. So for the DCDs in particular, we tend to procure our own DCDs. Yeah,
and particularly as a leader of a team, coordinating so many different pieces here of the procuring team, the implanting team, what's going on with the recipient, transplant coordinators. I have to imagine that's a logistical challenge to get everybody on the same page, on the same platform, kind of in terms of pulling off this sort of orchestra that it takes to make. I mean, and as you alluded to, it sometimes is members outside your own organization, friends and third parties. It's a whole network, a whole community that gets involved. Can you tell me anything about how you approach sort of helping that coordination come off?
And just to add to Michael's question, like some of our listeners may not fully are not aware of how the transplant recovery process works. So can you also share like how big is your team and what does a typical case require in terms of coordination?
Yeah, so we are 4 surgeons currently. 3 of them do organ procurements and the 4 of us do transplants. But that's just the surgical surgeons team. We have advanced practitioners also that are part of it. And I mean, it's an incredible amount of people. We start talking about pulmonologists and research coordinators, and we have within UPMC we have our own call center. So we have a group of people dedicated to us to screening offers and so on and so on. So we're talking probably north of 20 people that are involved in all this, and then in every specific case. We also get anesthesia involved. We also get the OR front desk involved, the nurses that are coming in from home for the transplant to the OR. So we have a lot of people. It gets crowded sometimes. Everybody wants to be kept on the loop. And we relied a lot on texting at different times, but then it's difficult to know exactly. Teams are not consistent the same as the day goes by. There can be people that kind of peel off of a particular time, or people that are being added in at different times. So we since we started using the Langar, we find the app that we have access with extremely helpful, because that eliminates the need to be keeping in the loop hundreds of different people at different times. Everybody's on page. Everybody knows the donor is in the room. There is a delay. The quality looks good. The organ has been accepted. We use all the features on the app. We share pictures. We share videos. Of course, we use it also as a way to keep track of our ischemic times and our temperatures and so on and so on. We added later on also with the reperfusion, how far are we from the center, ETA. So we have fully access. We use it a lot, and it simplified my life, at least, because I don't have to be answering of different phone calls or different texts from different people asking me, how do the lungs look? What time are we going to the OR? Every time a decision is being made, we put in this app, and it reduced significantly the amount of people that I had to be keeping in the loop through time. So they're all part of it. It's like a big group of people in these applications, so everybody knows real time what is happening, and that's what I find extremely helpful. We didn't have something like this made in house, so this was like a really good substitute for us.
That's wonderful to hear, and obviously our technology teams, we're passionate about finding good ways to help advance the field and make things more streamlined. And so anything we can do to make that more possible, I think, is important to the whole transplant field. Is really critical. And I think this is one of the truly amazing things that I always find in transplant. Is it's one of the few procedures that not only takes place for two patients in two different ORs, but also in two different often states. So, it can be incredibly. So the teams, to coordinate those teams, the timing is incredibly important, right? This is a very urgent procedure. So in this loop, it's not just an ongoing chain over days and weeks. This is all compressed into a relatively short period of time, is it not?
Yeah, you have some hours. I mean, I have to tell you also that we have used some of your technology as a way to alleviate the urgency to go into the OR right away. So I don't know if you know this. We are presenting in 24 the double ATS, our initial 20 patients in which we have done what we call semi-elective lung transplantation. So anytime we cross-clamp after 6 p.m., we don't go to the OR until the next morning at 7 a.m. And we have right now probably close to 22 patients in which we have an average ischemic time of 15, 16 hours. So I think we've gone up to 19 hours of cold ischemia. Of course, we haven't had any issues, so that's why we keep doing it.
What sort of historically, where did you usually try to keep your cold ischemic times?
Well, we normally, we'll try to be around anywhere between 8 and 10.
8 and 10.
Sometimes, we'll go up to 12 just because there was some kind of delay or something happened, But we will normally go to the OR at the same time the organs were being fly back.
So in the middle of the night, they'd arrive at 2 a.m.
Or 2 in the morning. I honestly can remember the last time I went at 2 in the morning. The OR probably was maybe 21, I think. So it definitely changed our practice. It made me probably one of the most loved surgeons for the night team because I don't bother them anymore.
Helped with your popularity with the team.
Yeah, it definitely increased my popularity here in the ORs. So it's been not only it is a completely different way to go about things. Starting fresh with a team that not regularly do the cases. So the anesthesia team is the team that normally does cardiothoracic surgeries, the nurse team. So you always kind of working with the same group of people through an increasing number of procedures leads to better outcomes. Right. So using also this technology not only for my convenience and not having to come at 2 in the morning, but at the same time as a team building skill strategy has been extremely useful for us. It just flows better. just because everybody, gets to do it all the time. So,
and you're able to partly do that because of that semi-elective nature. You're able to have enough time to do it during the daytime, bring those teams together, and coordinate and make sure that the right team is there. And I think all laughing aside, I think it's going to be a critical aspect is to have that solid team for such a critical operation. Yeah.
But it's not only the surgery, because, if we make incision around 7 a.m. or let's say we make incision around 8 a.m., we normally come out of the OR anywhere between 4 and 5 p.m. So even the receiving team in the ICU,
I see.
It's like middle of the afternoon. So it's easier also to kind of manage that initial phase of the transplant. It's just better.
Yeah, and this is really fascinating, and I'm curious when you introduced this change in practice. Obviously, your immediate team sounded like they were quite excited. Can you talk a little bit about the patient experience of being able to do the procedure in the morning, relative to before, where it could happen in the middle of the night?
Well, that's kind of funny that you asked me that, because the first time we did this, I think we were going to the OR. I don't know, 8 p.m. or something like that. And my coordinator was asking me, so what time you want the recipient in? And I said, well, honestly, it doesn't matter. Anytime. What time he came? 10 p.m. is fine. And she'll be, but we're going to the OR at 8 p.m. I said, yeah, don't worry about it. Just bring him 8. It's no rush. He doesn't have to be driving crazy to the hospital. He has time to come in. He doesn't need to eat anything after 11 p.m. or 10 p.m. or whatever. So it feels, of course, I'm not going to say that it's, that there are now some wrinkles here and there, but it's not as rushed as it used to be. So it makes everybody's experience better.
Right.
So not only the patient, but also the family and the processes of going through it. And of course, if we accept the organ, we let the patient know, okay, you know what, your lungs are looking good. We're going to be going to the OR tomorrow morning. Everything is okay. And, and go to sleep and wake up the next morning, and we'll get them to anesthesia like you getting somebody that came in for a completely programmed procedure. So it worked really well for us.
Yeah, that's an interesting point, right? Because for other kind of surgical procedures, there's a lot of prep involved for the patient, right? Like you mentioned, they should be fasting before anesthesia, et cetera. And historically with lung transplant, the patient probably couldn't do everything that they would have in another procedure.
I mean, the anesthesia teams are so good that they can get you through it. They can do like a repeat sequence intubation if you ate right before or something like that. But I mean, there are ways to go about this. But of course, reducing risk is always important. So anything that you can do to kind of eliminate kind of risk is good.
And I think one of the things that you touched on is it's happier for everyone involved. I mean, one of the things that's noted, I think, in some of the literature is that burnout's a real problem in transplantation, partly because of the 24/7 needing to do surgery in the middle of the night. And I have to imagine that that can be actually quite impactful and costly to a program to have, someone who burns out and gets tired and leaves to retrain a new person or be short-staffed and having to recruit a new surgeon or new staff. Having a stable team that can have a better longevity together, like you're saying, having that unit that's all together, I would imagine would be a real impactful part to a team. It's not just sort of that one day, but sort of the longevity of the program.
Yeah, I mean, most of the time when you look at outcomes, at least in lung transplant, comparing during the day and during the night, there's no significant difference. And I think it's because these. To be able to perform at this level, you got to be extremely committed to what you do.
Right, absolutely.
I'm not trying to say that operating in the middle of the night is dangerous, but operating in the middle of the morning, it's I think it would be everybody's choice.
It's preferable.
It's preferable, If you had to choose what time you want to For anybody, for the patient, for the nurses, for the physician, for the surgeons, you say, hey, what time do you want to get your transplant? 2 a.m. or 8 a.m.? Say, oh, I'll pick the 8 a.m. one,
Right.
So it's the outcomes probably will be the same, but the experience, I'm sure, is significantly different,
Absolutely. Can I ask you, go back to something you said right at the beginning, and I actually thought was really interesting. Coming back to sort of your leadership on the team, UPMC is a storied program, as you alluded to. You're not the first surgical director. There's been many surgical directors taking on that sort of mantle and the responsibility of shepherding or stewarding this program. Can you tell me a little bit about that, about what that was like, and sort of what you feel like that entails to ensure the strength of the program to serve the patients of UPMC?
Well, the beginning was intimidating for sure. When you start thinking about who occupied the chair before you, and they all people that are world recognized by being, the captains and generals of lung transplant, So it was a little intimidating to take on this job. But I have been extremely well supported by all my different partners here, by my chair, by my chief, by my partners, by my the pulmonary medicine group, and transplantation itself, not just lung transplantation, it's a bit of a team sport, So it certainly plays an important role, but so does everybody else, and what we do it might be 8-10 hours of work, but then it requires dozens of hours before to get that patient ready to get to the point, and then hundreds of hours after to get them to live as many years as possible. So of course, we all have a role within this. My job is to make sure that we get to find the best organ, we get to do the best surgery, and the patient has to get the smoothest post-operative course as possible. But I believe that you got to be well supported by everything else to be able to achieve that. It's not just me that makes all this happen. It will be impossible. And so I'm very grateful for everybody that I got to work at UPMC with. And one of the things that you realize through time is that that experience, the cumulative experience of having an infectious disease group that knows how to maybe take a little more risk on a particular recipient, or the pulmonary medicine group that has been able to take more risk on the selection of certain recipients, and then of course the surgical group that has been able to potentially get a little more complex cases through. All those additions eventually lead to being able to accept patients that maybe other centers don't feel as comfortable. Though, as you can see, the lung transplant, because it's a very collaborative environment, more and more centers are capitalizing on the experience of other centers and being able to also increase the risk that they're taking. So you can see there a few years ago, maybe 7-8 years ago, you only had a handful of centers that were doing more than 70 or 80 transplants. Right now, probably you have 15, and that's the result of of sharing experiences, and on being able to build your program not only on your outcomes but on the outcomes of others, and that's, in my opinion, extremely important.
And to that point, since you joined at UPMC, what are some of the key changes or changes in practice, or what donors were considered have you made? And just it would be curious to know how that experience has been to get the entire team on board with some of the new changes in transplant.
So I've been at UPMC for almost 8 years. And we've been able to, at the beginning, the DCD experience the early DCD experience wasn't the greatest. And we've been able to go from very little DCD use to DCD only with ex vivo perfusion, reevaluation to DCD directed to transplant to people feeling really comfortable about using DCDs. So that happened in this 8-year period. Then hepatitis C positive donors, which when in 2017, you were only able to get it if you were part of a clinical trial because of all the medications that were coming on board in regards to hepatitis C antivirals, and now it's completely part of our practice. Those are some of the things that we've been doing. Of course, some of the changes when it comes to preservation, some of the changes on the way we support people doing the surgery, a transition from cardiopulmonary bypass to central VA ECMO for support during the surgery and things like that. And of course, this undeniable period of time which we had to practice under a pandemic. At the beginning, we had absolutely no idea how to pick up a donor that potentially was in a hot zone for COVID, to having COVID testing for every donor, to potentially even using COVID positive donors, to transplanting people with lung disease with COVID. It was just bananas. You had to all that spectrum of things happen in 2.5 years. So a lot of changes.
And I think to your point of learning from peers, and as the beauty of sort of the scientific environment of medicine, of scientific meetings and sharing and learning from others, that was such a period, transplantation so small in numbers relative to other areas of medicine, that that was such a compressed period of time that it really took sort of a community collaboration and sharing of experiences and knowledges and approach to very rapidly learn. It's actually an amazing case study of knowledge sharing and learning and advancement of understanding in like you said, just 2.5 years completely changed things. And it was truly impressive. I mean, what was it like in the early days of the pandemic for you in lung transplantation? Did the program? The program, everyone was locking down and changing, and for an immune compromised population that also is a respiratory virus.
Right.
That must have been just a world of unknowns.
Well, it was all over the place, and during periods of time, like in every other medical system, the only thing that was happening in the hospital was COVID.
Right,
it was either people with COVID on the ICU, on the ventilator, or on ECMO, or for the long time, we didn't have elective surgery. A lot of the stuff that was going on was transplants. So our cardiothoracic surgery ICU would have maybe 10, 12 people that either had received a heart or a lung, and they weren't cabbages or aortic valves or anything like that, It was VV ECMO, waiting for a transplant, or trying to recover from COVID, or a lung transplant or heart transplant. That was our cardiothoracic surgery ICU for many months.
Right.
So definitely a period of time in which we had to rethink a lot of stuff on how to support our staff and different things. Also, in regards to donation, everything. If you remember, we didn't have a test for COVID for some time.
Right.
At all.
Yeah.
We didn't have a test, and then all of a sudden we have we were having a conversation at points with editorials saying, should we test every donor for COVID?
Right.
And now it's like, yeah, of course, everybody needs to get what were we thinking? Should we do a nasal swab or a BAL? What does it mean if you have one positive and the other negative? So, all that cumulative experience, all the things were things that we learned as we were doing. And it wasn't like everything was published. A lot of the stories say, it was a phone call. They say, oh, who is doing this? Let me give them a call and see what it is that we're doing. Or even getting transplanted and then getting COVID after transplant. What do you do?
How do you manage it?
How to manage it? What do you do with immunosuppression? Do they get an antibody? Do they get this? Do they get that? And then the vaccines come on board. Should everybody get vaccinated or not? Like I say, in period 2.5 years an incredible change in practice, and now it feels like things are slowing down, but we came out with all this knowledge that it made us better in a lot of ways. Before, if you have somebody bridging to transplant, you will say, well, they need to be walking and talking and this and that, and otherwise we're not going to offer them transplant. Now we know if they're younger, we might be able to rehabilitate them or post-habilitate them after a transplant. So they have, so also the way we bridge patients to transplant has changed, or how do we push how much they need to accomplish before a transplant has changed, just because of this comfort that was acquired on transplanting, particularly younger patients that were otherwise healthy, that now have a primary organ dysfunction with non-recurable lung disease. So fascinating. Right.
I mean, one of the things that we certainly noticed that was a change, particularly in the cardiothoracic space, was historically prior to the pandemic, very little local procurement. It was historically all out and back. The teams would fly out, recover the organ, and come back. And again, towards this sort of team sport community environment, there's been this big shift towards local procurement, where the team recovers it locally, and then the organ is sent back to the center. And I feel like was a tremendous shift that happened just in a period of 2-3 years.
Yeah, people had to adapt that way because, it's there
are places you couldn't cross state lines.
Yeah.
And can I ask, sort of in the spirit of collaboration and leadership, one of the things that kind of spoke to is being a team sport and all the different players, the pulmonology, the immunology, the nursing staff. As a teaching institution and your role, not only is your job potentially to teach the technical skills of being a transplant surgeon, but do you also have to teach that sort of leadership and collaboration of how to bring a team together to accomplish transplantation? I mean, it's one of the inherent requirements for the job.
Well, and you don't really have to, but it's always better if you do. Yeah. I don't think you're actively teaching people more than just modeling certain behaviors,
Mm-hmm.
It's just
role modeling.
Yeah, exactly. We're all a little different in our leadership styles. I don't think we actively, or at least I am not actively teaching leadership. I don't teach people how to be a leader. That's not what I do. I just, honestly, I'm just myself, and many seem to like that. so eventually people followed you because they kind of share your dream, or they share your passion and your dedication and your sense of humor, or your personality, of the way you your interactions with them, and how you value them, and how you recognize their effort, and that has always been the way I worked. So I guess, when you have somebody that is more junior and see you behave that way, and that you're able to congregate people to accomplish a certain goal, they can see that maybe that's one of the ways that you can accomplish this,
Absolutely.
So it's not like I teach leadership. I just have certain personal beliefs of what a leader has to be and needs to be, so.
I think that's fantastic. I have to imagine some of it was informed by your own mentor that inspired you towards transplantation.
It's very difficult to have. I don't think you can have one mentor, and you have different mentors that teach you different things. So you have some mentors that teach you how to be a very good technical surgeon. They have some mentors that teach you how to be a good doctor. They have some mentors that teach you how to be a good father, or and you have some mentors that you So, and then eventually you kind of make it your own. So,
so as lung transplantation moved through its journey, like you said, we just went through this period of 3 years of dramatic change. What do you see as a forefront for sort of the next phase? What do you see as the big challenges and changes on the landscape of transplantation, and what are you looking forward to?
Well, hopefully a little smoother sailing for a while until we
no more pandemics.
Yeah, exactly. No more pandemics, or at least a better understanding of how to manage or work around them. But I mean, we still have a lot of issues. We still have people that are not referred for a lung transplant that potentially need a transplant. So we still have we still need to educate the community and the referring physicians that transplantation or lung transplantation is not something that you need to think when there is no other option. That early referrals are important, that you might be giving that patient the best shot at having a successful and a meaningful post-transplant experience. The earlier you refer them, because you can, as a transplant team, you can get them better prepared for not only physically, but also psychologically and socially for a transplant, financially for a transplant. So the more time that you have for all that it's very important. You also have people that are dying in the wait list, still waiting for an organ. So how can we do better at that? Are we wasting any potential offers that we can still use and provide those potential patients with a better life opportunity? We still are one of the worst long-term survival organ when it comes to lung transplant. So we still need to work very hard on improving our long-term survival and understanding what is it that we need to change, particularly when it comes to early graft dysfunction or, longer-term immunosuppression and things like that, or even the chronic effects of the medications that we put our patients on, like diabetes and renal dysfunction and so on and so on. So we still have a lot of work to do.
Yeah, Dr. Sanchez, I'm curious from your standpoint and your experience, what do you think some of the reasons why the outcomes in lung transplant relative to other transplant procedures are so different? You kind of touched upon some of those, but like specifically to lung, what is it about the organ or the procedure that you think would require a lot of focus and innovation moving forward?
Well, I think everybody will answer the first part of the question the same way, which is the lungs are the only organ that are still communicating with the environment. Once you open the chest and you put the heart, that heart never sees the atmosphere again, or the kidney or the liver. The lungs are exposed to that environment with every breath. And how do you manage what goes in and out, and at the same time, how do you still keep those lungs from not rejecting, not getting infected? It's a fine line sometimes. At the same time, are there early indicators that we're still not fully aware of potential that as they progress can get that patient into trouble? And we're working on those. We have patients that get in-home spirometry, so every day they kind of gets you a baseline of what they might be. I am fascinated by all this wearable technology.
Really?
I think, if you're all of a sudden, your SATs are lower than they were before.
Yeah.
And
there's maybe something you should look into.
But there's something you should look into, or your heart rate is higher, or you have a fever. Those are, in a way, all signs of rejection. And can we use wearable technology as a flag? Not necessarily as a point of concern, but maybe as that alert mechanism that say, hey, you know what? When something might be going, your SATs for the last 48 hours have been lower than they were for the previous 2 weeks, or your heart rate is 10 beats higher, or your temperature has been in 2 or 3 degrees higher than it was before, and And not everybody calls their doctor.
Right.
We have to. And people some say, this is nothing. I'm just going through a little thing. It's going to get better. But maybe, why not use technology as a safety blanket? And there is a lot of stuff out there, that can be done. Glucose management. I mean, the amount of people that right now have this monitoring glucose, it's incredible to me. And so why not integrate all those technologies on the long-term care of these patients? It is, we limited in the number of people as just to give you an idea, a post-transplant coordinator as an average is taking care of anywhere between 40 to 70 patients. So why not make that transplant coordinator life easier, incorporating some of these technologies?
Yeah.
I completely agree that, so many of those pieces and technologies, the pieces are out there. And putting them together in a meaningful way to solve the problem for a coordinator, manage a large. I mean, if our goal is to increase access to organs, reduce waitlist deaths, do more transplantations, and increase overall survival and longevity, that challenge of post-transplant management is only going to get bigger as that population, which is a great thing. But we need to take advantage of the tools that are out there.
And I'm curious. Patients who get specific transplant in terms of follow-up compared to other patients that are not transplant patients but received another medical procedure, what's your experience been in terms of how different that patient population is in terms of follow-up, discussing any potential changes in their health? Are they similar or is there any fundamental difference there?
Yeah, I think overall it's similar. I don't think the lung patients are significantly different from a heart patient or a liver patient. Sometimes, the trigger of the disease are different. You can say, it might be that this patient had a cirrhotic liver because of alcoholism, but at the same time, we have people that have COPD because they smoked 80 packs per year. So, we all sometimes have these habits that led to the need for transplant. So I'm not sure that there are significant difference between the patient population. Might be, I think in certain organs, like for a kidney transplant, we were just talking yesterday, they go to a BMI, they were having a conversation on a BMI of 38 to 40. We would never consider for lung transplant somebody that BMI of 38. So we're more like, 32, 33, 34, sometimes 35, depending on how the habitus of that patient is. So there are, differences, but I don't know if the patients per se are the complexity of the social complexities are any different.
It's also the balance point of treating more patients versus making sure those outcomes are really good. It's sort of with the donor pool in the U.S. versus Europe is very different, and so they'll transplant much older donors in Europe versus the U.S. But the U.S. with public reporting is a big focus on outcomes and long term. So I think there's it's always a balance point to sort of trade off all the different factors you're considering.
Well, I think, the donation thing between Europe and the States is mostly based on the differences in the trauma and the overdose impact that those two situations have on donation. They don't have that amount of trauma in Europe. Right. And that's why I think they are extending the age. But at the same time, when you look at how they extended mostly with people in donors that were not significantly smokers. So it's a calculated risk also,
Right.
It's not that. And in the United States, definitely you have to be a little more careful in regards of who you offer in transplant to, because for better or for worse, we're subjected to these metrics that everybody uses to define what kind of program you are.
Right. Absolutely.
So and then insurances use it as for reimbursement. So so the question many time becomes this line of how much risk is too much risk, and
both for the patient and the program.
Well, it's an unfortunate circumstances to be put in, but because of course you want to save as many lives as possible, but then at the same time you have a limited resource. So who do you operate these to is also, that's why these decisions are never made by one person. That's why we have committees.
Right.
And we all try to make the best decision that we can, based on the data that we have at that particular time. So, it can be difficult,
But then I have to say, coming back to sort of the beginning, I have to imagine when you do a transplant and see the patient who had been struggling to breathe, having sort of end stage lung failure, seeing that transformation has to be incredibly rewarding, and be able to see that change in just a few weeks time after transplantation.
Well, my favorite part of the job is when they send me the card and they're the fishing, or they are picture in front of the Christmas tree. That to me is people sometimes ask me, "Oh, what is the favorite part of your job?"
Right.
When I get to see them back to normal, or you run into them in the corridor and you don't recognize them because they look so different. The hair is stronger. They walking like they have no limits and outrunning you sometimes. And so it is extremely rewarding to see somebody that way.
That's
and
incredible.
I think that's what keeps you going.
That's incredible. That's wonderful. I truly appreciate you making the time, and I want to thank you for what you do. It's incredible work, and we're grateful that you've made the time to share your thoughts and your experience with us.
Yeah, thank you very much. This was fun.
All right.
Thank you, Dr. Sanchez.
Thank you.